All right, welcome to this explainer. Today we're unpacking a really heavy but absolutely crucial topic, the overwhelming burden on pediatric mental health emergency services. But we're not just going to talk about the problem. We're going to explore 3 incredible evidence-based strategies to actually fix it. If you've been following the healthcare landscape recently, you know this is a critical issue. We're going to dive into real clinical data, look at actual patient cases, and even check out some advanced population modeling to see exactly how we can reshape care for our youth. So let's just dive right into it. Upwards of 500,000 pediatric patients, 500,000 kids and teens. That is how many are visiting emergency rooms every single year for psychiatric crises. And honestly, the staggering part here is that for a lot of these families, the emergency room is literally their very first point of entry into the mental health system. I mean, they haven't seen an outpatient therapist. They haven't been in a specialized program. The ER is their front door. And right now, that front door is completely jammed. We are seeing a massive deluge of pediatric mental health crises, just totally overwhelming hospital emergency capacity. Because of the stretched resources and incredibly long waits, this surge means our most vulnerable youth are sitting there in acute distress, waiting for care in a chaotic environment that, let's be real, was fundamentally built for physical trauma, not for ongoing mental health treatment. But hey, it's not all doom and gloom. There is actually a lot of hope in the medical literature. Here's our agenda for today. 1. The pediatric ER crisis. 2. Inside the emergency room. 3. Diverting through telephone triage. 4. Modeling system-wide solutions. And 5. Reimagining mental health care. We're moving from individual hospital floors all the way out to massive population-level reforms. First up, inside the emergency room, navigating the front lines. Let's start right there on the micro level, inside that high-pressure hospital environment where the actual clinical model used completely changes a patient's outcome. Now, to really ground this data, let's look at a real-world scenario. Meet Mary. She's a 14-year-old girl who arrives at the ER after taking 15 aspirin pills 2 days prior. She actually hadn't told a single soul until she confided in a friend, who then told Mary's mom. Mary has undiagnosed ADHD, struggles heavily with math, and suffers from intensely low self-esteem. Her story really helps us intuitively grasp the profound difference between ER treatment philosophies. You know, in a super rapid assessment, a clinician might totally miss the root of Mary's distress. But with just a bit more time, the ER team finds out that Mary's father routinely calls her stupid and lazy when she fails those math exams or avoids her chores. These incredibly toxic verbal put-downs were fueling her internal dysphoria. This is a deep-seated adversity, an environmental trigger that simply cannot be resolved by a quick 15-minute hospital discharge. And this brilliantly illustrates the exact paradigm shift we need on the front lines. Think about it. The standard triage model means a doctor spends maybe 15 minutes checking immediate suicide risk. It's fast, sure, which helps busy ERs, but it totally misses the root cause, leading to higher return rates. But then, look at the crisis intervention model. This takes 1 to 3 hours with a multidisciplinary team of psychiatrists, nurses, and social workers. For Mary, they actually identified her ADHD. They shifted the narrative so she understood her struggles weren't because she was lazy, but because she had a treatable neurodevelopmental condition. They even counseled her dad on the toxicity of his words. This model actually treats the family distress, shifts the youth's narrative, and significantly lowers the chance of them ending up back in the ER. A total game changer. All right, moving on to section 3, diverting through telephone triage, intervening before the ER. Because while treating kids better inside the hospital is obviously vital, what if we ask how we keep them out of the ER entirely? Enter the Pediatric Psychiatric Telephone Triage Service. This is a free, confidential support line built specifically to intercept these psychiatric emergencies before the family even gets in the car. By catching caregivers in that exact moment of panic, highly trained clinicians, we're talking master's-level social workers and advanced practice nurses, can evaluate a child's risk right over the phone, provide immediate de-escalation, and direct them to outpatient services. It saves immense time, emotional strain, and crucial hospital resources. And when we look at the data from a major study on one of these triage lines, it's pretty clear who relies on this safety net. Desperate caregivers make up the vast majority here, over 75%. This absolutely proves that families are actively searching for guidance. They don't necessarily want to go to the emergency room. They just literally don't know what else to do when their kid is in crisis. Schools and providers make up another roughly 23% combined, using the line to prevent unwarranted ER trips straight from the classroom or the clinic. And just to be clear, these are not low-stakes calls. When that phone rings, clinicians are rapidly triaging intense symptoms. Nearly 29% of calls involve suicidal ideation. Another 23% are about physical aggression. These clinicians are making incredibly high-stakes decisions on the fly, making this screening service a critical link to early risk identification. They have to figure out, does this child need a hospital bed right this second or an urgent outpatient appointment tomorrow? But here is the absolute mic drop moment. Look at how effective this diversion actually is. Less than 10% of these calls required an emergent, same-day hospital visit. Less than 10%. The telephone lines successfully diverted over 90% of callers away from the ER. 40% were scheduled for an urgent evalu within a couple of days, and almost 29% were referred directly to care services like partial hospitalization or outpatient therapy. I mean, that is a massive victory for both the families and the healthcare system. Okay, section 4, modeling system-wide solutions, the macro view. So we've looked at the individual hospital room, we've looked at the telephone line. Now we are zooming way, way out to an entire population, looking at a fascinating study from the Australian Capital Territory that uses mathematical system dynamics modeling. Now, okay, I know this map looks incredibly complex. It's a massive web of arrows and feedback loops covering everything from education and employment to psychological distress and mental health services, but essentially this just allows health planners to mathematically simulate how changes in the community ripple through the medical system. It's basically like a highly advanced flight simulator, but for public health. By pulling very specific structural levers inside this computer simulation, researchers figured out exactly which community interventions would break the gridlock at the hospital doors. They tested it all, expanding general mental health capacity, deploying mobile crisis response teams, enforcing strict follow-ups after patients are discharged, and providing targeted education to families. And the proof is right here in the numbers. Deploying mobile crisis teams, which means sending mental health nurses alongside police or paramedics to de-escalate situations in the community, reduced youth ED visits by 10.2%. Making follow-up calls to patients after they leave the ER to make sure they're safe dropped visits by 6.4%. And simply providing psychosocial education to the families of people with schizophrenia limited frequent returns by 5.1%. But wait. The real magic happens when you stack them. When you combine all of these targeted, population-level strategies together into the simulation, the model projects a triumphant 26.6% total reduction in youth mental health ER presentations over a 10-year period. That's over a quarter of all visits prevented entirely, just by building a smarter, more proactive system. Absolutely incredible. Which brings us to our final section, reimagining mental health care from triage to prevention. Bringing it all together, we've seen that solving the pediatric psychiatric crisis is not some impossible pipe dream. It is entirely doable, but it requires a multi-layered approach, stretching from that individual interaction all the way to the entire population infrastructure. So let's pull all these threads together. Here are your main takeaways from this explainer. First, when kids do end up in the ER, taking the time to use a crisis intervention model to unpack a 14-year-old's real adversity completely changes their narrative and keeps them from coming back. Second, highly trained clinicians answering a telephone triage line can intercept and de-escalate crises right in the living room, diverting 90% of callers away from the hospital. And third, utilizing advanced system dynamics modeling lets us mathematically deploy community resources like those mobile crisis teams with true surgical precision. We have the evidence-based tools to fix this. The data is crystal clear. The answer isn't just more hospital beds. So I'll leave you with this final thought as we look toward the future of pediatric care. When facing a crisis of this absolute magnitude, are we going to settle for just building bigger waiting rooms? Or are we finally going to build better systems? Thanks so much for joining me on this explainer, and keep asking the big questions.